Okay, so next presenter, we have someone who also doesn't need too much of introduction. So Lizheng, who's another one of the leaders in the Weatherhead School as well, who's going to be presenting on diabetes complications. Let me pull up these slides.
Okay, thank you for nice introductions. And also, this is kind of summary the work we're done in the last 8 to 10 years. And I have recognized several people in this room, our RET support, Oscar, Ken, my grad student, and some students already graduated and now faculty in the other leading institutions. So I'd like to since I've been asking to talking about how we can using the AI machine learning to improving the risk engine or risk predictions. So first of all, I'd like to kind of talking about some case work we are doing. This is about our teams. We have a building, relating, accessing, and validating outcomes. I call this short-term Bravo risk engines. So Bravo risk engine basically taking the population data. So this problem that could be a clinical trial data, could be claims data, could be EHR. And we're building a set of the risk equations, and then we call this a risk engines. This is trying to deal with a disease we typically dealing with. This has a multiple chronic conditions. It's not just a single outcomes. And then we further using the machine learning and AI to enhance is a diagnose ability, validities, and also clinical utility. So I'm showing this in the next few slides. So just kind of give you a quick framework about the artificial intelligence for health promotion and chronic disease prevention. So we will know that we want using lot data, big data, from the social demographics, some survey, from their nutrition patterns, some genetics, genomics, and then some other, their early lifestyle, and some very important physical activities. So this kind of big data analytics and integration is certainly we're using the AI-powered decision making. And then that will certainly give us a better personalized health promotions. And sometimes we can also helping the clinicians do the clinical decision makings. So I think our team's kind of fundamental kind of study question is that can we be more accurate in individual risk predictions? In the past, we have some risk predictions only can be using for cohort patients, and now we kind of in the step to really getting much more individualized. And then we looking at those individualized risk prediction, how that could be give the information for better public health interventions. Is that going to be helping them to have a better diet? I'm thinking sometimes that if we can go in there and then they can send pictures about their the meals, and then we can use the meals and we can getting the idea about their general kind of the nutrition intake. And also, we also can looking at whether or not they have a following the medication adherence. All things could potentially get a lot of individualized clinical plans for the chronic care condition makings. And finally, is that matters. You have excellent predictions. Okay, you have a very good plans. Can this kind of better targeting of interventions could lead to better health outcomes? Right, so we need having a very rigorous assessment on how we can move the needle to really improving the outcomes in chronic care. So I like to kind of do this using the ADA and then ESRD's kind of platform for the precision medicine. So we can go to very upstreams about the risk predictions, right? So we understand disease risk factors, the mechanisms, some natural histories, and then we're using a lot of biomarkers and some using the monitorings, wearable device, those kind of things, potentially could be included in our as risk factors. And then we can integrate all those risk factors into a risk prediction engines or any like product. There's obviously now the FDA's and regulatory agency now have pathways for us to further making this kind of risk prediction into a potentially a clinical applications could be using in a clinical practice. But to make this kind of happening, you also need good engagements with patients and clinicians, make sure that they have a good usability, user interface. And then because the time limits, I also using this kind of risk engines for a health economics analysis, which is this part. And then that's going to be driving the health policy decision making, which is payers. So we have providing a lot of good work for the pricing for a GLP-1, which is a tirzepatide. We make a recommendation for what kind of price is going to be a cost-effective price. And then potentially we can also talking about some whether or not we need to cap the insulin co-payment $35. Why $35, not $40, $45? So we also make some a simulation to make these kind of recommendations. We further even make a recommendation on if you want reducing the insulin price, is going to be reducing 60%, 70%, 80%. So we also make recommendations, and then actually the company follow the recommendation and do exactly the same percentage reduction in their insulin price. So all this potentially could have a lot of good use cases using the big data risk predictions. So we have done two main kind of clinical translations. One is in the prognostics, right? So we can use in precision prognostics, looking at the clinical environment characteristics and put into predictive algorithms. Then we can put their 5 years, 10 years, maybe longer terms, cardiovascular risk, retinopathies, cardiovascular disease, neuropathies, kidney disease, and then some other disease. And we'll put them into some patient-centered outcomes measurement framework. So that's kind of one translation we're very interested about. So one thing, particular example, is this is a work we're working with the US CDC and then looking at, okay, so if you're having a patient come into your clinic, right? So this person's have a lab report, have a very poor glycemic control, lipid control is not good, and sometimes also having some hypertension, right? So if you look at this one, this is what I call is a heat map. So from here, you potentially can find a person. That could be a woman, their age groups, their blood pressures, their BMI, their A1C, and bottom is the LDL, okay? So for this kind of patients, are you going to intensify their anti-diabetes treatment or intensify their anti-hypertensive treatment, right? The more intensification obviously has risk associated with those kind of intensifications. So we did some predictions and tried to figure out, okay, so if this person, which is a woman, roughly the middle age, and have high blood glucose, and then the BMI is in the 30, and then has also LDL 130, the blood pressure is 160. Okay, so what thing you can do to help them the most? Okay, so through our model simulations, what we can say is that if you are focusing on their blood pressures, we try reducing the blood pressures from 140 to maybe compliance with guideline, which is under 120. Actually, you potentially can extend their lifetime by 3 years. Instead of you try to do this is reducing their BMI to like a 30 to 25, give them expensive weight loss drugs, and then and actually only can improve by 1.2 years. So this could give us a ability to make very precise decisions and also recommendation for patients. And then they can have a shared decision making between the clinicians and the patients. Last one we're working on is that we're also using Bravo translations for diabetes therapeutics. Now we know that when I was in the medical schools, I was actually having 2 class of anti-diabetes drugs. Okay, now it's have more than 15. Okay, and give that a wealth of those medication treatments. What kind of a better treatment might happening, and what kind of recommendation class of the anti-diabetes drug need to be recommended? So we need to have a tool to guide or make recommendation for a better or precise treatment recommendation. So that's something we potentially could using the AI powered Bravo translations. So simple examples for example, like SGLT2 inhibitors for heart failure preventions. Based on literature, it looks like they can reducing the risk by 40%. Okay, so we have 2 different persons. The person might have a 50% risk heart failure without SGLT2. Okay, and then if you can reduce in relatively by 40%, that means that in 5 years their risk only like 30%. And then given these 20%, that 4 additional years to live, that gives us a 2.5 QALYs potentially. And for a different person, quite healthy, right? So this is obviously an example. It's kind of extreme about this kind of different 2 persons. It's important for us to get in. So a person walking in, we can having a clinical decision tool, individualized treatment. So treatment A, treatment B, treatment C, then obviously then one of them could be potentially be adopted by the patients and also the providers. Very important is that we cannot just have a standalone application. We have to integrate that EHR. So our team's also using the FHIR and Smart on FHIR technologies So can develop these applications and working well with all kinds of different EHR platforms, like Epic, Cerner, all the things. And then we also test this among the clinicians. We achieved like 81.25, which is indicating a very good, excellent usability for the platform. So in conclusions, I think we're in a stage where working at Tulane at the School of Public Health and working with the medical school, we're really thinking that there's obviously can further using AI to improving the usability of risk engines and better communication between the care team and patients. So there's a lot of AI features we can use in analytics, all of this. And then obviously we have a natural language processing and natural models in healthcare. But there's no way that AI can replace the healthcare providers. It's still a health provider still in a loop. They're going to make a final decision. But I think it's going to have a very good, reliable AI tool. It's going to be helpful, improving efficiency, reducing costs, improving outcomes. So I'm stopped here. Thank you.